A very good afternoon to one and all. At the outset, I would like to thank AIOS2025 for giving me this opportunity. My study is titled Etiology, Management and Visual Prognosis in Patients with Orbital Apex Syndrome, a prospective study. I have no financial interest to disclose. As we all know, orbital apex syndrome is because of the involvement of the anatomical structures at the orbital apex due to compression, vasculitis, or direct invasion. It is characterized by vision loss, ophthalmoplegia, periorbital pain, ptosis and proptosis, with or without diplopia, with or without hyposthesia of the forehead and diminished corneal sensations. The etiologies are varied. High resolution contrast enhanced MRI brain and orbit, mainly the fat-sat sequences, help in the most accurate characterization of the pathological processes involving the apex of the orbit. The purpose of this study was to determine the etiology, management, and visual prognosis in patients with orbital apex syndrome and to find out the predictors of final visual outcomes. This was basically a prospective study. 15 patients who were diagnosed with orbital apex syndrome were included, and the study period was from January 2024 to June 2024. A detailed ocular and systemic evaluation was done for all the patients, and the patients were managed as per the underlying etiology. A minimum of 6 months of follow-up, 3 months of follow-up was done. A detailed statistical analysis was done, and a p-value less than 0.05 was considered to be statistically significant. Now coming to the results, the mean age of the study participants was 34.67 plus minus 0.38 years, and there was a male preponderance with a male-female ratio of 1.5:1. In the etiology, infective etiology was most common, amounting to around 53.3%, followed by the neoplastic etiology, which was combinedly noted in 27%, and then the traumatic etiology in 20%. In the neoplastic etiology, 2 patients had nasopharyngeal carcinoma, and in the infective etiology, around 33% patients had sinusitis. Now, the organisms isolated were not seen in 7 of the patients out of the 15, whereas the most common organism isolated was Staphylococcus species, including aureus, angiosus, and epidermidis. In the ocular symptoms, diminution of vision followed by drooping of the eyelid were the most common ocular symptoms, whereas headache followed by fever were the most common systemic symptoms. This is the data showing the different treatment given in all the 15 patients as per the underlying etiology. On comparing the best corrected visual acuity in logMAR units of the affected eye, from presentation there was a 2.06 logMAR unit which has improved significantly to a BCVA of 1.05 logMAR unit at final follow-up, and this was statistically significant with a p-value of 0.0001. On comparing the pupillary status of the affected eye, the most common pupillary finding at presentation was a grade 2 relative afferent pupillary defect, which has improved to a sluggish pupillary reaction at final follow-up. We did univariate and multivariate regression analysis, and the factors which affected the final visual outcomes came to the BCVA of the affected eye at presentation, presence of systemic comorbidities, fever at initial presentation, neoplastic etiology, presence of higher grades of pupillary abnormalities, and advanced field loss at presentation. Now coming to the discussion. In a study by Lee et al. In 20 cases, there was male preponderance with a unilateral presentation being more common. Neoplastic etiology was the leading cause, followed by inflammation and infections. There was no significant difference in the initial and post-treatment final best corrected visual acuity in these patients. Neoplastic patients had a poor visual prognosis, and the over visual prognosis was poor in these patients, despite a vigorous multidisciplinary management. In a study by Talwar et al. In 117 cases, 52% of the patients experienced improvement in vision, whereas around 85% developed improvement in the ophthalmoplegia at 6 months. In a study by Ribeiro et al. On 4 cases, all of which were males, and there was a mean age of 61.2 years, all had a neoplastic etiology. In these patients, delayed diagnosis led to fatal outcomes. In a study by Schindler et al. In 6 eyes of 4 cases of nasopharyngeal rhabdomyosarcoma leading to orbital apex syndrome, the average age at presentation was 4 plus minus 1.4 years. There was marked loss of vision at presentation. Ocular motility almost recovered in almost all patients, whereas 4 of the 6 eyes had little or no recovery in the visual acuity at final follow-up. In our present study, out of the 15 cases, there was male preponderance with a mean age of 34.67 plus minus 0.38 years. Most common etiology was infective, followed by neoplastic. Most common organism isolated was Staph aureus, and there was a significant improvement in the best corrected visual acuity at the final follow-up. As orbital apex syndrome is a disease which is very rare and there is heterogeneous etiologies, there is paucity of literature and mostly there are small-scale studies. Most patients experience poor visual prognosis despite giving an aggressive multidisciplinary management. The patients with non-neoplastic etiology usually are found to have more favorable outcomes as compared to those with malignant etiologies, because the patients with malignant etiologies, they're usually diagnosed late and thus they have poor ocular as well as systemic prognosis. So to conclude, a careful clinical workup, relevant laboratory investigations, spatial diagnostic modalities like incision or excision biopsy of the orbit, along with a histopathological and microbiological examination and proper neuroimaging in proper, mostly the fat-SAT sequences, are the crux to establish the correct diagnosis and start adequate treatment. Delayed diagnosis and treatment, presence of neoplastic etiology, presence of osteomyelitis and intracranial and extracranial extensions, systemic comorbidities, and severe visual impairment in terms of vision loss and advanced field loss at presentation are the predictors of poor visual prognosis. There is a need for large-scale studies with more sample size. Thank you.
Thank you. We have time for one question.
Incidence of, you have put infectious as the commonest etiology, yes. But was there any association of HZO, herpes zoster? Because
no,
many times we tend to see presenting with painful total ophthalmoplegia.
Yeah, in this 15 patients, there were no patients with HZO, but yeah, after this, I have come across 2 patients with HZO
because
who
that
have
is
presented.
also one of the commonest we tend to come across in a case.
Yeah, good comment. Yeah. Thank you so much.
Thank you.
So we invite the next speaker. Could you, Dr. Lee, and could you tell where you're from?
Okay.
Yes.
Good afternoon, everyone. My name is Chen Yong Lee. I come from the National Taiwan University of Taiwan. I come from Taiwan. Mm-hmm. Yeah. And thank you for having me at the 40th APO Congress. So today I'm going to present our study on the vascular modification after transsphenoidal endoscopic decompression surgery, for suprasellar tumor. And this study was conducted at the National Taiwan University Hospital, and I have no any conflicts of interest to disclose. To start with, suprasellar tumor can compress optic chiasm, leading to visual field defect and visual acuity loss due to retrograde degeneration of retinal ganglion cell and compromised blood flow. So OCTA is a non-invasive tool that can be used as to assess the retinal microvasculature and also serves as a surrogate for vascular changes in the optic pathway. Since a previous study reported inconsistent postoperative microvascular alteration, this study aims to evaluate the retinal and choroidal microvascular changes after the decompression surgery. And we also want to identify potential microvascular markers predictive of visual recovery in this scenario. So we conducted a prospective study at the National Taiwan University Hospital between March 2022 to November 2024 on patients receiving endoscopic transsphenoidal surgery. The inclusion criteria included patients aged 18 years or older with an MRI-confirmed suprasellar tumor who were scheduled to receive the transsphenoidal endoscopic decompression surgery. And the exclusion criteria included any other ocular diseases that could affect vision, such as glaucoma, diabetic retinopathy, or a prior history of retinal surgery. We also do perform pre- and post-operative assessment, which is including visual acuity, fundal examination, perimetry, and OCTA. So all the included patients is classified according to their visual field defect severity, which is classified into 3 levels: minimal, mild to moderate, and severe, based on mean deviation value, with cutoffs at -3 and -6 decibel. And also, there's a deep learning tool which is used for choroidal segmentation, which is called choroidalizer, and and we also conduct statistical analysis with p-value less than 0.05 considered statistically significant. So in the end, our study included 89 patients with a mean age of 52.48 years, most had pituitary adenomas, and almost all the patients exhibit significant improvement in visual acuity after decompression surgery. And there's also a notable enhancement in visual field function, as reflected by mean deviation improving from -674 to -328 decibel. The vessel density of superficial capillary plexus, or SCP, significantly decreased in patients with severe visual field defect. And the SCP vessel density loss is particularly pronounced in the inferior macula, which may be more susceptible to conversion-related damage. The preoperative SCP vessel density and the vessel density of radial peripapillary capillary, or RPC, and the GCC thickness were found to be positively correlated with better postoperative visual outcome. So, on the other hand, in mild to moderate visual field defect cases, foveal vessel density may also serve as an indicative marker that is predictive of visual improvement. And choroidal vascular index, or CVI, show no overall changes, but varies across quadrants. The nasal CVI increasing in mild VFD cases, while the inferior CVI decreasing in severe VFD cases. This finding suggests a possible region-dependent vascular responses or localized vascular adaptation. In the end, this study is limited by a single follow-up visit and a small subgroup sizes, and there's also a lack of direct vascular measurement, direct vascular flow measurement. So future research should incorporate serial imaging and advanced vascular assessment. And in summary, supracellular transphrenoidal decompression surgery significantly improves the visual function of the supracellular tumor, but the visual recovery is dependent on initial severity. And our study also confirms that chiasmal compression can lead to region-dependent retinal degeneration and vascular alteration. Furthermore, in severe VFD cases, it might show that show a significant SCP and RPC microvascular changes. And the SCP vessel density loss is particularly pronounced in the inferior macula. In the preoperative SCP and RPC vessel density and GCC thickness may serve as a good predictor of postoperative visual outcomes. And in mild to moderate cases, foveal vessel density also a good predictor for visual recovery. And this is our study. Thank you for listening.
Thank you. Any questions? So I believe what you have shown is an additional marker for prognosis.
Yes.
We normally use the ganglion cell or the RNFL as a prognostic marker.
Yes, right.
And you're determining if the macular superficial capillary plexus thickness.
So we want to know that whether vascular components can also predict the postoperative visual outcomes.
Thank you.
Yeah.
Thank you so much. We have Dr. Gurung next presenting the neuro-ophthalmic manifestations in traumatic brain injury, a hospital-based study, and we'll learn where you're from. Yeah.
Thank you. I'm from Nepal. So good afternoon and namaste to all of you. So my topic for today is neuro-ophthalmic manifestations in traumatic brain injury. It's a hospital-based study.
Yes.
It's not good. Next slide. Okay. So I have no financial disclosure. So introduction. So we all know head injury is associated with neuro-ophthalmic manifestations, and there is consequent visual morbidity. And there can be afferent or efferent visual systems which are likely to get injured during traumatic brain injury. So for any kind of head injury, ophthalmic evaluation is very important for the localization of the injury site, initiating proper management and treatment so that we can prevent permanent visual deficit. So with this, we did a study to study various neuro-ophthalmic findings in patients with head injury and correlate them with the nature of head injury, neurological status, and neuroimaging findings. So in methods, it was a hospital-based cross-sectional study where all the patients with traumatic brain injury, which was diagnosed by the neurosurgeons and was treated in the Gandhi Medical College Teaching Hospital in Nepal. The study was done for 6 months period, and ethical clearance was approved from IRC of GMCTH. We excluded the patients who had previous ocular disorder or nerve paralysis, patients with multiple system injuries, broadened cases, and no informed written consent. Coming to the results, a total of 377 head injury patients underwent neuro-ophthalmic examinations, of which 38 patients had neuro-ophthalmic findings, and male were more commonly involved than the females. And the mean age of the patients in our study was 38.6 plus minus 16.8 years, and the youngest was 3 years and the eldest was 85 years of age. And also the time from injury to ophthalmic examination was very important, and in our study there was from 30 minutes to 12 days, and the mean duration was 24.2 plus minus 18 hours. So the mode of injury in our study, RTA, we all know it's been increasing day by day because of the increased urbanization as well as the increased use of the vehicles. So it was more common in our study also. Male were more commonly affected, followed by fall injury, physical assault, and blunt trauma. And for the ocular presentations, so simply when you use see the ocular presentation, traumatic this injury, the floor fracture or vital floor fracture was the most common injury ocular manifestation, followed by lid laceration, ecchymosis, even intraorbital foreign body. So the commissure retinae, retinal detachments, these were the ocular findings in my study. Whereas looking for the severity of head injury and pupillary reactions, in our case, we found the moderate and severe head injury patients had RAPD of 5 and 8 respectively, compared to the mild head injury cases. And for the neuroimaging and neuro-ophthalmic findings, so when you do the neuroimaging, contusion was more likely associated with traumatic optic neuropathy in 28.9% of the cases, and intracranial hemorrhage, which was extradural, subdural, or intraparencranial hemorrhage, in which we saw there was a few cases of the neuro-ophthalmic findings. And skull fracture is basically was associated with fourth nerve paralysis, was seen in 13.2% cases. Looking at the severity of head injury and neuro-ophthalmic findings, we found the mild cases head injury patients were associated with efferent nerve defects, that was the third and fourth nerve where paralysis was seen, whereas in moderate and severe, more number of the traumatic optic neuropathy. So discussions, young males were affected, and the ocular involvement in our cases was 70, whereas the neuro-ophthalmic findings we could find was 10.1%, is compared to Kumari et al. And Sujata et al. Study. And the efferent deficit was more common than the afferent, trochlear nerve being the most common. So it may be because the trochlear nerve being the longest nerve, it is close to the tentorium of the bone, so it's more likely to get injured, that we found in our study, similar to GP et al. Study. And optic nerve injury was seen in 36.8% and chiasmal in 52%. And our study showed that the contusion was associated with traumatic optic neuropathy and ocular motor nerve paralysis, whereas skull fracture was significantly related to trochlear nerve paralysis. So neuro-ophthalmic manifestation is what's common in the is head injury. Mild head injury, it may be because it is very easy to access in patients with mild head injury, whereas it is difficult in the severe cases. And also our limitation in our study was it's a single center study. However, if we could do the multi-center study of similar nature, then we can estimate the proper prevalence of the neuro-ophthalmic deficit in our country. So ocular deficits and neuro-ophthalmic manifestations are very common after head injury, and pathologies like brain contusion and skull fracture were significantly associated with neuro-ophthalmic deficit, and also pupillary involvement was associated with the severity of head injury, whereas severe cases of head injury had RAPD positive. So this study acknowledged the need of routine ocular examination in head injury patients. So these are my references. Thank you very much.
Thank you so much. Any questions?
I have one brief question. I am Professor Jha. I had occasion to work in Nepal and see similar kind of patients. I like to ask you one thing. Although your paper is basically to reporting the neuropathic manifestations, yes, did you try to study the effect of say use of helmet or eye protection in the incidence? Because the incidence of your traumatic the optic neuropathy is 36%, very high. So is there any effect of that? Did you see any how different are the patients who are not using the head protection, the eye protection, and
Oh,
those
we
who are,
didn't do
who
that,
came with
sir. We didn't look over that. So
Oh.
maybe in the future we can do that.
Okay, thank you.
Yeah,
Thank
good,
you.
good follow-up.
Thank you.
Yes, thank you. We have Dr. Malik, clinical presentation of carotid cavernous fistula and outcomes of endovascular balloon embolization. Is Dr. Malik here? Taiba Malik? Okay. Let's move on to Dr. Hartono. Efficacy and safety of gene therapy for LHON, a systematic review and meta-analysis.
Okay, good afternoon, all the participants of APAO 2025. Thank you for being here. My name is Michael Hartono from Indonesia, and I would like to present my free paper titled Efficacy and Safety of Gene Therapy for Leber Hereditary Optic Neuropathy, a Systematic Review and Meta-Analysis. Okay, first of all, to start off, LHON is a mitochondrial inherited disease caused by a point mutation in the mitochondrial DNA and only inherited when the mother is affected. This disease is the most common mitochondrial optic neuropathy disease with an estimated prevalence of 1 case in 30,000 to 50,000 births. The disease has a strong male predominance with 80 to 90% cases. This disease age of onset is between 15 to 35 years old, which are mostly at productive age. Current therapy for LHON primarily focus on supportive care and rehabilitation, which do not treat the cause of the disease. Considering the shortage of low vision services in many developing countries, LHON patients can be classified as legally blind and require substantial social assistance. Gene therapy is still challenging to implement in many countries, and more studies are required to gather more data on its effectiveness and safety profile. Therefore, the systematic review and meta-analysis aim to update the current development of gene therapy for LHON with this outcome measure. These are the outcome measure. For the primary outcome was change in visual acuity expressed in logMAR. The secondary outcome in this study includes mean defect, visual field index, OCT assessment such as RNFL and also GCL, quality of life assessed with the Visual Function Questionnaire 25, and also safety profile based on the occurrence of adverse event. Our systematic review included studies that met the following criteria: RCT or cohort studies, clear description of the outcome, and also we limited the publication in the recent 10 years. A total of 6 studies were included. 3 studies was RCT and 3 studies was cohort. All of the studies compared the gene therapy with control group, with sham injected or uninjected. And then meta-analysis to measure the mean difference was done using the inverse variance and fixed effect model. Forest plot analysis showed that there is no difference in mean BCVA value at the end of the follow-up between treatment and control group. We also 5 studies reported change in BCVA at the end of the follow-up compared to the baseline, found no significant difference in BCVA change between treatment and control group. But 2 studies noted the improvement in BCVA relative to the baseline. The study by Mann et al. At 2020 reported significant improvement in BCVA in both the treatment and control group. We also, using the same analysis methods used in the mean BCVA, mean difference between treatment and control group was done. And then we can see at the forest plot analysis that there is a significant difference in change of BCVA favoring the gene therapy with a more negative BCVA change found in treatment group compared to the control group. And then we also analyzed the visual field. 4 studies presented the difference in the visual fields, with 2 reporting is as visual field index and 2 as mean defect. For VFI, Wan and Yang found no significant difference between the treatment and control group. However, Wan et al. At 2016 noted a significant improvement in VFI in the treatment group. A meta-analysis was conducted for the MD, as we can see in the forest plot, showed no significant difference mean defect at the last follow-up between the treatment and control group. 2 studies reported no significant difference in RNFL at the end of the follow-up between treatment and control group. For quality of life, the greatest score increase were observed in the dependency subcategory, which rose by 130% from the baseline, and in mental health, which increased by 108% from the baseline. Other clinically significant improvements are noted in near and distant vision and role limitation. But the smallest score increase was in the ocular pain subcategory and social functioning, color vision, and peripheral vision. For safety profile, found that this gene therapy was generally well tolerated with no serious adverse event reported. For the strength of this study were low risk of bias with the involvement of patients from various countries that officially registered for the clinical trial and the usage of efficacy parameters to be objectively analyzed and have a good heterogeneity. However, this review is not without limitation. Due to the early phase, we still have the small sample size in some studies, and not all the studies recognize the visual field, OCT, and safety, and have a variability of follow-up duration. For the summary, LHON is a serious condition that leads to blindness and currently lacks sufficient treatment options. Lenadogen nolvaprevec, a gene therapy, has been developed to meet this need by specifically targeting the M11778G mutation in mitochondrial DNA, the primary cause of this disease. While the gene therapy demonstrated notable efficacy in visual BCVA, other functions like an MDVFI show no clinically significant change. However, the improvement in quality of life and the favorable safety profile emphasize the potential benefit of this therapy. Thank you for listening.
Thank you. This is a lot of hard work. So congratulations. Are there other meta-analyses on this topic?
Not yet.
No, okay. So wonderful, good effort. Thank you for sharing the results. Any question from the audience?
Sorry?
I think the question that was posed to you was how do you differentiate Leber's from other causes of optic neuropathy? Is that correct?
Exactly. So you told 15 to 35 is an age group where it's Leber's. So how do you differentiate whether it is Leber's or not?
I think it wasn't truly the purpose of your study, but do you want to address that? Or do you want me to address that?
I cannot find the data for...
Yes, no, I think that's not the purpose of the study, but in general, it is after you've evaluated, you may diagnose initially as optic neuritis, you may presume that that's it, but then you find out that they're not responding to steroids, there's no enhancement of the optic nerve, and then you test for gene. It's a genetic testing that you can be secure after you get that.
Okay.
Yeah.
Thank you.
Thank you.
Thank you. Okay, we have Dr. Magdalena. I don't want to butcher your last name, so you can. So the effect of intravenous atropine bolus on pupil diameter in patients undergoing cardio-neuro-ablation. And a request, please keep conversations out of this room. Thank you.
Dear Chairman, ladies and gentlemen, thank you very much for the opportunity to present our study. So the idea of our study came randomly during our interdisciplinary talk with my colleagues from cardiology department. And then I noticed how worried they are when they notice enlarged, dilated pupil. So I wanted to relieve them and try to find some studies according to this topic, but actually I couldn't find anything proper, so that's why I helped them to evaluate and to check what's happening with the pupils in some kind of conditions. Pupil diameter assessment is critical in rapid evaluation of neurological status of patients undergoing different procedures, including those undergoing ablation. The surgical techniques in cardiology are...
It's not advancing. Do you want to advance?
Yes.
Yeah.
Oh, sorry. I got lost.
Yes.
The ablation procedures are being constantly improved and they are quite safe, but the ischemic risk still can occur, and the study estimates that their frequency is around 0.5 to 1%. One of the new ablation procedures is cardioneural ablation. This is a method of treatment for patients with arrhythmias influenced by parasympathetic hyperactivity. An essential element of developing patient to that procedure is atropine bolus test. This test helps to estimate what is the parasympathetic influence on heart rate, and helps to predict how the heart rate will behave after the proper cardiomodulation. However, the impact of this atropine bolus in medicine, including its impact on pupil diameter, has not been thoroughly studied yet. Actually, there are only few studies with different methodology concerning this topic, but they led to contradictory results. So, in our study, all the patients who were evaluated into cardioneural ablation procedure underwent the baseline measurement of the pupils just before the atropine bolus administration, and it was followed by subsequent measurements just after the atropine bolus, 3 hours after, and 16 hours after the bolus. And this is how our study group was structured. In general, it consisted of these bradyarrhythmic sequences. And these are our results. We can notice that just after the administration of atropine, we have the significant pupil diameter, that it increased significantly. We can notice that the largest peak occurred 3 hours after the atropine bolus, and it also was noted that 16 hours after the administration, the pupil was still significantly enlarged. And this is the example of one of our patients. We can see on the left side the baseline measurement. We can see the normal size pupil with accurate reaction to light. And after 3 hours, we can see the significant enlargement of the pupil. And I would like to underline this, that it still presents accurate reaction to light, which is very important for our friends to calm their nerves, because it shows that there is no problem in a neurological system. And these are the changes in the heart rate. We can see that the heart rate was affected directly after the bolus. And after 16 hours, the impact of atropine bolus was minimal. And these are our conclusions. Intravenous administration of atropine significantly affects pupil diameter in patients undergoing cardioneural ablation, and this effect persists in 16 hours observation, while 16 hours post-atropine administration, atropine influence on heart rate is minimal. Thank you very much for your attention.
That's a very clever study, so congratulations.
Thank you very much.
So just to clarify, you said the pupil response is intact to light reflex.
Yes, exactly. And it's symmetrical.
Yeah.
In all the patients, it was symmetrical, so there was no disproportion. So that helps our colleagues not to panic when they see the enlarged pupil.
And why were they worried in the first place, like just the bilateral larger pupils, worried that it wasn't anisocoria?
They are afraid of anisocoria. They are afraid.
But there wasn't anisocoria.
No, never, never appeared. And in our study, all the patients, they didn't have any side effects of the surgery, so there was no brain infarction.
Okay, great. Thank
Fortunately.
you. Any questions? Yes.
So did you also take it after 16 hours to tell the cardiologist that this is when it comes down?
Yes, so our study lasted for 16 hours because the patients who are admitted to the hospital for these procedures, they stay only overnight, and then they are dismissed from the hospital. So this was the maximum period of time that I could reach them over there. But it could be interesting to make a longer follow-up, and we are thinking about some ideas to continue.
But you showed there it was coming down after.
Yes, a little bit, yes.
Just a little bit. Okay. Yeah. Thank you.
Thank you.
Dr. Jin, methanol-induced optic neuropathy treatment and outcome of case series from Singapore National Eye Center.
Hello. Hi, good afternoon, ladies and gentlemen. My name is Eric Jin, and I'm a final year medical student from the National University of Singapore. And today, I'll be presenting our study on the clinical presentation and treatment outcomes of methanol-induced optic neuropathy with high-dose corticosteroids, a case series. I have no conflict of interest to declare. Methanol-induced optic neuropathy is a severe and potentially irreversible complication of methanol poisoning, affecting up to 50% of methanol toxicity cases. It often results in bilateral progressive vision loss due to metabolic acidosis and mitochondrial dysfunction caused by the accumulation of formic acid. While outbreaks are more common in developing countries, sporadic cases still occur in developed nations such as Singapore. In view of the limited data on this topic, our study aims to review the clinical presentation, ophthalmic investigations, and treatment outcomes of patients diagnosed with methanol-induced optic neuropathy at SNEC. We conducted a retrospective case series of patients diagnosed with methanol-induced optic neuropathy presenting to SNEC from 2006 to 2024. We analyzed baseline demographics, clinical presentation, ophthalmic investigations, as well as treatment responses. Patients with other optic neuropathies were excluded from the study. We included 6 male patients with a median age of 37.5 years. The median time from methanol ingestion to treatment initiation was 5 days, and most of the patients ingested methanol through beverages. At presentation, all patients experienced acute bilateral progressive and painless vision loss associated with systemic symptoms such as headaches, nausea and vomiting, abdominal pain. Clinically, bilateral optic disc swelling was seen in 4 patients. Most patients had poor initial visual acuity, with 7 out of 12 patients presenting initial VA equal to or worse than 1.80 logMAR. Visual field testing was performed in 3 patients, of whom 2 had Humphrey visual field test and 1 had Goldman visual field test. The HVF showed moderate to severe central visual loss, and the Goldman showed bilateral central scotoma. The remaining 3 patients were unable to complete the visual field testing due to profound vision loss. 4 patients underwent OCT, RNFL, and GC-IPL testing, and with the remaining 2 patients not having the test due to their visit taking place significantly long ago. The initial median RNFL thickness was 121 micrometers, and the median average GC-IPL thickness was 70.5 micrometers. All patients were treated with IV methylprednisolone at 1 grams per day, ranging from 3 to 5 days, followed by a tapering course of oral prednisolone ranging from 6 days to 3 months. Patients also received supplements such as vitamin B, folic acid, ginkgo, and coenzyme Q10. There were no major complications observed, except for 1 case of steroid-induced hyperglycemia, which was promptly managed by the endocrinologist. After treatment, most patients showed some degree of visual improvement. 3 patients showed bilateral improvement, 2 patients showed unilateral improvement, and 1 patient had bilateral worsening vision. Overall, median visual acuity change was an improvement of 0.34 logMAR. Among the 2 cases who had Humphrey visual field testing, 1 exhibited significant bilateral visual field recovery, while the others had bilateral minimal improvement. 1 patient recovered sufficiently to complete a visual field test. All 4 patients who had an OCT, RNFL, and GC-IPL testing done demonstrated progressive RNFL and GC-IPL thinning over time, with a median RNFL thickness decrease of 32.0 micrometer and an average GC-IPL thickness decrease of 13.5 micrometers. Our study highlights the clinical characteristic of methanol-induced optic neuropathy, which predominantly affects young males from developing countries and typically presents with acute, painless bilateral vision loss with accompanying optic disc swelling. This is also associated with mild to moderate central visual field loss, as well as progressive RNFL thinning. After treatment with IV methylprednisolone and tapering oral prednisolone, most patients experience some degree of visual acuity and visual field improvement. And these studies were consistent with previous studies suggesting that corticosteroid therapy may help stabilize or improve vision in methanol-induced optic neuropathy by reducing inflammation and demyelination in the optic nerve. However, visual recovery remains unpredictable, and though our small sample sizes limited statistical analysis, neither age nor time to treatment appeared to correlate clearly with recovery. For instance, case 4, who was older than case 3, showed more dramatic visual acuity improvement, while case 2, who started treatment within 1 day, experienced a deterioration of visual acuity post-treatment. Other potential factors that have been found in other studies to affect treatment response included age, methanol dosage, and concomitant ethanol consumption. Vitamin supplementation such as B12 and folic acid may also support methanol metabolism, but they remain off-label in clinical practice. Our study was limited by small sample size, lack of comparison to other treatments, as well as retrospective nature. There were also some incomplete investigations for some of the patients. In conclusion, methanol-induced optic neuropathy remains a serious but treatable condition. Early recognition and prompt initiation of high-dose corticosteroids may improve visual outcomes. However, larger prospective studies will be needed in the future to validate treatment protocols and identify prognostic factors that may influence recovery. I'd like to extend my gratitude to Dr. Ruben and other doctors at SNEC for their guidance and support.
Thank you. You did a great job as a medical student presenting this. Is your mentor here?
No, he's
okay.
yeah.
I just had a question or a comment that the steroid use. I don't think your study you cannot conclude that steroids are helpful, and I don't think there is data on that. So I don't want the audience to go back home and think that that's the treatment for. And I know others in the audience may have experience with methanol toxicity, and what if they want to comment on what their yes.
It's quite common in my country, in Indonesia, but I'm surprised that in Singapore, they can have.
Can we get a microphone, please? Or okay.
Maybe this is not a medical question. It's just it's quite commonly found in my country still, Indonesia. But I'm quite surprised that they can access it in Singapore too. Is it is it really easy to access in Singapore this methanol, or illegal?
I personally do not have any contact with such substances, so
no source.
But I believe that Singapore has quite tight regulations on alcohol consumption as well as sales. So maybe it's not as common with some of our patients actually consuming overseas, but they will be transitioning through Singapore during their presentation, and that's why they end up presenting to SNEC.
Thank you. Yes, and I think somebody I'd heard someone from. Either Scotland or Ireland somewhere, they said the people working in the whiskey factories, they take it before it's finally ready, and that early forms they may take from the factory and use it, and that's contaminated with methanol. So it can happen in developed nations too that way. Yeah. Thank you so much. Yeah.
Actually, we tried steroids in this. We had 2 to 3 patients of this kind of poisoning, but there was no improvement. When we gave zinc supplements and oral neurovitamins, rather there was much better improvement as compared to that when we gave steroids. Intravenous methylprednisolone followed by oral steroids. That is our experience.
I think it's a tough situation. There may not be any improvement with any method. That is what we should remember, but hemodialysis might be the best possible thing along with all supplements. We may not have definite improvement.
That is true. Like, what is the natural history? Do we know if there's no treatment, some may improve on their own, or I don't know. So I have no experience, so I cannot comment, but I don't think it's going to be hard to prove, right?
There will not be any randomized study to tell for this kind of disease. But at the same time, as a supplement, many things can be tried. Mitochondrial cocktail, we can call all of them together with vitamins, antioxidants, citicoline. But definitely there may not be much improvement. It's a hard situation. Hemodialysis might be the best method to treat in the acute phase.
Yeah, so I think the points are treat the systemic toxicity. I do less harm by maybe mitochondrial cocktail doesn't hurt. So thank you.
Thank you.
We have Dr. Lee again, Huang Dong. Sorry, I might not be pronouncing it correctly. Retinal neurodegeneration, topic. Nobody's here? No. Dr. Tan, neuroprotective effects of lyceum. No. Dr. Tan again? No. Then Dr. Wulandari, or sorry, can you pronounce your name correctly for me?
Wulandari.
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 Please, correlation between retinal nerve fiber layer thickness and severity of cognitive impairment in Parkinson's disease patients. They're bringing up your slides. Do we have the next two presenters, Mahar Khan and Mingsu Shi? No? We have time for discussion then.
Okay, thank you very much. Okay, thank you for your invitation here today. I'm Fadila Putri Wulandari from Hasanuddin University, Indonesia. On behalf, it's an honor to presenting our work, the multidisciplinary study between ophthalmologists and the neurology department. I have no disclosure for this study. Here is the background. Neurological diseases are the major cause of disability worldwide, and the prevalence of Parkinson's disease is increasing faster than any other neurological disorder. And estimated that 6.1 million people were diagnosed with Parkinson's disease, and 2.4 times higher than 1919. And this increasing prevalence is due to improvement in method for detecting and diagnosing the disease, and greater awareness of the disease, aging population, longer life expectancy, and also perhaps increasing environmental exposure. And the recent evidence indicate that dopamine, as a neurotransmitter, plays an important role in the retinal visual processing, and previous studies have found that phosphorylated or misfolded alpha-synuclein accumulated in retinal cell and progressive retinal degeneration of Parkinson's disease. Some evidence has shown that assessment of retinal thickness can provide parameter in distinguish healthy subject from patient with the neurodegenerative disease. And previous study has also revealed that the thickness of retinal nerve fiber layer and macula and fovea is reduced also in Parkinson's patient comparing to healthy patient. Another study have also described the relation between RNFL and the disease of progression, which is going to be raises the potential applicator of RNFL thickness as a clinical marker for Parkinson's disease evaluation. Therefore, based on this, study will be conducted to the thickness of RNFL for Parkinson's disease with the cognitive impairment. And the study design using case control study with analyzing RNFL thickness using optical coherence coherence tomography and also mini-mental state examination by the neurologist. And the thickness of each retina sector, comparison the RNFL value and MMSE value for the degree severity of the cognitive, and assessing the correlating between RNFL, the cognitive score, with taking inclusion criteria from the neurology outpatient, and they also will be divided to the cognitive impairment to normal cognitive, and then after we got it, the cognitive impairment will be divided as mild, moderate to the severe. Here the result, we found that 25 sample, and we find that divide to the severity and characterizing according to the gender, degree of Parkinson cognitive impairment, and retinal nerve fiber layer. We found mild cognitive impairment as the most common cognitive we found because of patient cooperative because the eye movement. Then the average of the thickness itself, the retinal nerve fiber layer, the study, we found that the thickness one is the inferior temporal and the thinnest one is the temporal sector. OCT examination, we found that each research subject, currently no significant correlation was found between OCT segment and severity score. And can we see, we found the most temporal inferior quadrant has p-value less than 0.05, which is, means that significant relation between the degree of cognitive function of the OCT result. And it's shown the three group from normal, mild. We divide the three groups from normal, mild, cognitive, and moderate to severe cognitive impairment with each p-value more than 0.05, which is mean it's not statistically significant. And it's shown that the difference from the thickness of the RNFL itself has the disturbance of cognitive suffering from Parkinson based on result from OCT measurement in 7 quadrant. And for the correlation between RNFL thickness with MMSE scoring to cognitive impairment, by Pearson test, we found the correlation test carried out from each quadrant. There is no relation between the thickness of RNFL and the degree severity cognitive from the Parkinson patient. But we found that the most strong, slightly stronger relation between from temporal inferior. For summary, there is significant difference from RNFL thickness between Parkinson patient from temporal inferior quadrant comparing to Parkinson patient with cognitive impairment. And for RNFL layer have a strong negative correlation to MMSE parameter, and we need longitudinal follow-up in larger, more population with similar staging. And for the research is needed for the determine whether ocular coherence tomography will be relevant as the biomarker to predict the Parkinson disease diagnostic. Thank you.
Thank you so much. Any questions for the last speaker? So I think, if I understand correctly, it's not very sensitive. It's hard to. You wish you could have a OCT biomarker, but we are not there.
Yeah, because the neurology department has have MMSE for diagnostic, but it's very the long to diagnostic. So we think that how about OCT can be more be very quick to diagnostic, but I think it's not.
Yeah, and I think people have done OCTA as well, and nothing has shown.
Yeah.
Thank you.
Thank you very much
for sharing. We have I don't think we have any other speaker here, correct? What? Oh, you okay? Please. Wonderful.
Yeah. Okay. Okay, thank you for being here today. My name is Hyunjin from Seoul, South Korea. I'm going to talk about neuroophthalmic findings of a visual snow syndrome in South Korea. Okay, I have no financial disclosures. Okay, great. So what is visual snow? Visual snow is a neuroophthalmic condition characterized by persistent visual disturbance such as a flickering dot in the whole visual field. So individual visual snow may experience that after image or polynopsia, photophobia plural, or decalopia. Visual snow can have a significant impact the person's quality of life. A visual snow patient may suffer from anxiety and depressions. They undergo some medication about that. So, however, a visual snow has a poorly understood etiology and lack effective treatment modality. In this regard, in this study we investigated visual snow syndrome in Korean patients. We focused on the visual and non-visual symptom of the patient and potential trigger of the visual snow syndrome, and neuroimaging findings, and lastly, treatment responses. Here is the method. We retrospectively study who visited our hospital, and from 2021 to 2024, we excluded 2000 meet the criteria, and we collected patient symptom data using Colorado Visual Snow Scale questionnaire, and patient underwent MRI scan and brain PET scan to evaluate their brain structure and function. We also reviewed the treatment responses such as various medication, including lamotrigine and alprazolam, SSRI, and so responses about their use of filter glasses like FL4 lenses. Here is the result. This study involved 63 patients with an average age of 27 years. Mean age of onset was 24 years. This is the demographic of the visual snow patients. As you know, visual snow symptoms often affect the young adult. And there, among the visual symptoms, flutter was the most common, and followed by polynopia and blue-pilled and toptic phenomenon. Regarding to the non-visual symptoms, anxiety and depression is the most common, and followed by tinnitus. These results show a similarity with Western cohort in previous study, suggesting that visual snow patient may they have a similar symptom profile across different population. Interestingly, among the patients surveyed, 35% reported they have a specific trigger event. So among that, 64 patients reported ophthalmic procedures such as LASIK and fundus examination in the hospital with a bright light or ERG, and other 63 patients, they mentioned that their visual snow symptom caused by some infection medication and or psychological stresses. Another interesting finding is that among the 22 patients, PET can show hypermetabolism in the primary visual cortex. In the 85% of patients, suggests that visual snow syndrome may have hyperactivity of their visual cortex. In contrast, MRIs can show no abnormality in all patients. This result implies that in the patient with a typical visual snow syndrome, brain MRI may not needed require. When it comes to treatment response, effective medication varies significantly. Most of the treatment provide only partial relief. So, for example, lamotrigine, they provide only 20% of patients partial relief. However, filter glasses like FL4 lenses provide 32% of patients partial relief without any complication. In conclusions, this study has enhanced understanding of visual snow syndrome by identifying potential trigger such as ophthalmic procedure like a LASIK surgery. Also, this clinical manifestation of a visual syndrome in East Asian population are comparable to those observed in Western population. Finally, functional neuroimaging such as a PET scan could also serve as an objective tool for diagnosing visual snow syndrome. Still, visual snow syndrome is still enigmatic. Still no effective treatment. The patient may have multidisciplinary treatment strategy combined with filter glasses as well as psychological stress management will improve their quality of life to the patient with visual snow. Thank you so much for your attention.
Thank you. That was very instructive, and I love the slides. Your background of visual snow. Any questions? I see a comment and a couple questions. Yeah.
I have a query. Like, if in place of FDG PET, can we do MR spectroscopy? Because MR spectroscopy also studies the metabolism of the brain tissues. So have you tried doing this in any of your patients?
Oh, that's a great question. So you're right. Functional MRI scan, functional imaging is very useful tool for visual snow patients because they have no other abnormalities. So brain MRI is normal, OCT normal, visual field normal. Every exam is normal. So that's the problem. Sometimes in Korea, in Korea we are do our military service mandatory. Some patient, hey doctor, I have visual snow, so I have noise on the whole field. So could you give me some certificate? Just could you give me some medical report about my visual snow? And this is a very tough case. Interestingly, PET scan, you may right. So some functional imaging scan. I have no experience about other functional MRI scan, but some of the modality functional imaging have some can be used for objective tool for diagnosing visual snow syndrome. So this gonna be a very currently now visual snow syndrome, the diagnosis criteria is only composed of just the symptom criteria, and we have to put more objective tool into the diagnosis criteria, right?
So I think we can try for MR spectroscopy also.
Yeah, right. Thank you. Thank you so much for good comment.
Yeah, thank you.
There's a question. I'll take yours next. Thank you.
First of all, congratulations on getting so many people to do a PET scan for visual snow. That's rather unusual, and I'm not sure who funded all the PET scans. The patients with the visual snow, were they all having constant visual snow, or were any of them having intermittent bouts of visual snow? In your series?
That's a great question. So all of them have a constant visual, static in their visual field.
Right.
If the patient have intermittent static, we can, differentiate patients such as migraine or, occipital seizure like that. Most of them complain about 24-hour static in their visual field, but some of them, hey doctor, during the nighttime, my noise is a little bit, decreased, and sometimes I can ignore it, not disappear. Some of the patients can ignore. We have to differentiate this, alleviated symptom is totally gone, or just they can ignore. If they can ignore, it could be visual snow, but it disappear. We have to differentiate from other, similar pattern of disease, seizure, occipital seizure, or migraines, aura. Thank you for your question.
Yeah, thank you.
Please.
My only concern was that is PET justified, because there's a lot of exposure to radiation for answering, maybe for the people who are very troubled by it, but would know you can't really go in for a PET. There's a lot of exposure to all radiology.
You're right. Yeah, thank you so much for your comments. So nowadays we do not anymore PET scan patients. So we're gonna change our research in functional MRI and other imaging technology. But I wanna mention one more comment. So we actually PET scans almost 30 patients, but I have to comment on this. We did not compare to this PET scan hyperactivity to, there is no control in our study. That's the problem. So in the future study, we have to gather some control patient comparing to their, visual snow patient PET scan and other who have no other, have no visual static patient. We need a control scan. So we have to interpret this result of the study very carefully because we have no control.
Yeah. I was going to comment that functional MRI studies in visual snow have actually shown some thalamic hyperactive. Are you familiar with that literature? What has the functional MRI shown?
So functional MRI show, so if a patient, if you give a patient some stimuli, So we, glucose uptake, or we can imaging which area of the brain's hyperactive, and so with the visual stimuli. So you mean
in visual snow?
In visual
snow, there is literature on
yeah,
functional
some
MRI.
lingual gyrus hyperactivity, but unfortunately we analyze which area of the brain is hyperactive, but we found that lingual gyrus is not a primary focus of the visual snow.
In your
in our study. So we're gonna publish which area of the brain is a hyperactive area. So a couple of months later. So, but not a lingual, a lot of lingual gyrus. Yeah.
Yeah. So I think the conclusion is that there isn't any definite study available yet.
Yeah. Right.
Yeah, and you're working on that, and we have a comment.
I just wanted to ask one condition, like Charles Bonnet syndrome. Is there any way clinically, like you can differentiate this condition if we don't have a functional MRI?
Yeah, I think I'll just say that the description is the description is very different, and you can comment more on this as well.
So your question is differentiation of the visual snow syndrome, is it right, ma'am?
From Charles Bonnet, yes.
Charles Bonnet. So Charles Bonnet syndrome, first of all, Charles Bonnet syndrome is caused by some visual loss or visual field loss, and we have to confirm that if the patient should have no auditory component in Charles Bonnet syndrome. Also, they have a clear so mindset about their image, or their image is not real. But in visual snow syndrome, the visual acuity is normal, 20/20, and visual field is normal. There is no scotoma. So that's the most difference part of the Charles Bonnet. Charles Bonnet syndrome, they have a decreased vision or loss of visual field. They have no auditory component, but visual snow patient, they have a tinnitus. And Charles Bonnet syndrome also, they know that is not a realistic image. So they have a clear recognize there is visual field abnormality. So image is not real. So but visual snow syndrome is totally different. So normal visual field, normal visual acuity, and auditory component and tinnitus. Yeah.
Yeah, I think that's a good.
That's a great question. We also gather their contrast sensitivity data, but all the contrast sensitivity data was more normal. Yeah, right. Yeah, but some of the previous study found that ERG of the visual snow patient, they have some ERG response is very hyperactive comparing to the control patient. So results show that maybe visual snow patient, they have some retinal hypersensitivity in their cone cell and rod cell. Yeah, but we need more data. The study only analyzed 8 patients. It's too small data. Thank you for your question.
Does having visual snow allow them disqualify from the army?
Yeah, that's a great question. So
in your country.
In your so that's very great question. But in my case, I just wrote them. This is a very subjective symptom, subjective diagnosis, according to their patient. So we can meet the criteria, but it's not a very subjective diagnosis. We cannot confirm. So, but in some patients, they have definitely PASCAN hyperactivity. In such a case, I'm able to write more, so with more confidence. And this patient have some objective imaging diagnosis, like a very hyperactivity in their visual cortex. In such a case, I'm gonna add some more, detail about their objective sign.
They might be fooling you by looking at a visual task, and causing hyperactivity.
Right.
Yeah, it's
That's great.
complicated. Yeah,
You're
it's
right,
complicated.
you're right.
Okay. Thank you so much.
Thank you.
Good discussion. I don't know if you have Dr. Khan here. Dr. Khan, and then we have Ming Zhu Shi. Okay, I don't think we have. So we will close this session, but we had, I think, just summarizing the visual snow was a fun way to end, right? And anybody in the audience has visual snow? Okay, so not in this audience. And in India, what is your is it on the increase? Do patients present complaining of this? We heard definitely in my clinics in North America, we have patients. They're usually younger, and we use the same scale, the Colorado scale, for recording their data, and that's a good one to use. Because then you kind of have a way of recording in each patient, But in India, what's your experience? I see Indian neuro-ophthalmologists in the audience. Do you see visual snow much?
I keep it in mind now, because sometimes they do say vague things and we never used to. Maybe I'll use the scale and try to see where they fit.
Mm-hmm. Dr. Karthik? In Aravind, just two patients. So, yeah, people are not hyper focusing here. They're more relaxed. As a static and all those symptoms. Mm-hmm. And did you have comment?
There is increased awareness about the diagnosis, and people are coming with the complaints, but to say that they are actually having with the imaging findings, as of now, it is not so much there.
Yeah, I don't think they have imaging findings, and we are not imaging patients with visual. If they have typical visual snow, no MRI. Yeah. Okay.
Yeah.
Thank you so
Thank you.
much. Congratulations. Yeah.